And Dr. Lalit Gupta was an associate professor at Maulana Medical College, where I also come, would discuss this. And his area of interest are pain, difficult airway, onco-anesthesia, palliative care, and intensive care, and a big smile. So, Dr. Lalit Gupta,
thank you, sir.
On to your speech.
Respected organizing committee, my dear friends and colleagues, and dear students. Today we are going to discuss a very important topic in anesthesia, that is the ERAS. Although ERAS saying traditionally means for the NS recovery after surgery. But since we are anesthetists, we should know the component of anesthesia that is important for NS recovery after surgery. I am Dr. Lalit Gupta, Associate Professor, Maulana Medical College. I am taking to the tour of ERAS. So as you know, ERAS refers to the evidence-based protocols that sterilize care to minimize surgical stress, response, and postoperative pain. It reduces complications, improve outcomes, decrease hospital length of stay, and expedite recovery following elective procedures. So what is actually ERAS and how it has been developed? So because the anesthetists are the main important part of the surgery, they should know all the components which are important for them. Now coming to the history, there was a research group of surgeons from North Europe in 1997 that made a study in initially group, which later on converted to 2000 to the ERAS study group and finally the ERAS Society, which lays down the requirements as well as the guidelines for various surgeries. Now, if you see this chart, from 1995, where only a fast-track surgery was done, to the 2005, where the ERAS protocol for colorectal surgery was made, in between a study group of 2010, ERAS study group was formed, followed by the protocols for colorectal and pancreaticotomy surgeries, followed by ERAS Society, then cystectomy, then guidelines for the gastric section for breast, and finally in the bariatric neck and liver. And now the ERAS is a part of the all-day care surgeries in every hospital. So what is actually ERAS guidelines about? So if you see, they are the specialty-wise anesthesia to the bariatric to the thoracic surgeries. All specialties are there, and these are the various surgeries where ERAS is important. From the gynec surgery to GI surgery to gastrectomy, radical cystectomy, pancreaticotomy, bariatric liver, head and neck, esophagectomy, and lung surgery. So all the major surgeries at present are having a component of ERAS. So again, my question is, what is ERAS and why the standardized protocol is important for them? So if I say ERAS is a multimodal intervention which decreases the operative stress, supports the organ function, reduces the morbidity, and accelerates the convalescence of the patient. That is, it decreases the hospital time the patient is admitted in the hospital, helps in the early recovery and early discharge. If you see this graph, this is the lower one is the traditional one, and where the patient is discharged, and this red one is the ERAS graph, means the how early his patient is discharged from the hospital as well as gets early and he becomes better than before. So it's a multimodal intervention if you see, and it has a component from the pre-op information, the stress attenuation, pain relief, exercise, enteral nutrition, nurses, surgeons, to the anesthetist, physiotherapist, and dietitian. But we should know the part because anesthetists are the backbone of any surgery, and this part is more important for them. So it's a multidisciplinary approach where anesthetists are the rider. How? So if you see, I say ERAS protocols have some key characteristics which decides from the home to the home, and in between the part are the preoperative, intraoperative, and postoperative, which is managed by the anesthetist. These brings from home to home concept become the ERAS recovery in anesthesia. So as I told you, it's a multidisciplinary pathway which is evidence-based, patient-centered, designed to reduce the surgical stress, includes rehabilitation, involvement of the patient in their own preparation or recovery. So these are the actually a study was done where all the components was laid down, and it has been shown that the parts which are played by the anesthetists are very important. They start from the patient education, pre-op optimization, abstinence from the smoking and alcohol, the proper guidelines for them, the fastings, carbohydrate loading, pre-medications, intra-op management, antibiotics, post-op nausea vomiting, and pain reliefs. And again, the post-operative fluid management. So all these are the various parts which are basically a part of your anesthesia. That's why ERAS after anesthesia is very important for us. Although if you see the rest of the part which is left for the surgeons and the paramedical staffs are very low, and in most of the part the recommendations are high for the anesthetics. So we must know each and every step of ERAS. Coming to the what are the factors which influence the patient recovery in ERAS. Now, if you say what are the various factors which delays the recovery, they start from anxiety, fear, surgical stress, hypothermia, nausea, vomiting, starvation, poor sleeps. And what accelerates the recovery in the post-op period? They are the pre-op optimizations, abstinence from the alcohol and smoking, neuroaxial blocks, normothermia, no nausea, vomiting, good sleep, and post-op pain management. So if you see, the cycle starts from the pre-op to the post-op and post-op to the pre-op again, where the education, nutrition, optimization, pre-warming, and preempt oral anesthesia are the part of the preoperative, while the intra-op part comes for the regional anesthesia, short-acting opioids with the goal of normothermia, volemia, antibiotic prophylaxis, and blood conservation surgery so that less blood is required in the post-op. While post-op periods involve the multimodal opioid-sparing analgesia, our blocks, early mobilization, early oral intake, and the various procedures to decrease the post-op nausea and vomiting. I will be discussing each point with their recommendation in detail. So the very first part is the patient information and consent. So the patients, when are caught, they are the recommendation is very strong for them. A proper counseling in the pre-op period is very important for them, which helps in reducing the anxiety, improves their compliance. They should know the what will happen to them in the post-op period and how much pain they are going to relieve and what are the various measures, when they should stop the taking the foods and what are they nutrition they should build before taking for the major surgeries like anemia and other managements. This involves the pre-anesthetic assessment, where you should observe for the general health assessment, the optimization of comorbidities. If the patient is very obese, you should take the stop bank score. You should also take care of the ASA grading and the risk for the cardiovascular and pulmonary risk. Prehabilitation, it's a modified term which means from pre-op to the post-op period, where the respiratory and cardiac muscles are strengthened, and it involves the nutritional counseling, protein supplementation, anxiety reduction, and moderate exercise program so that patient is better performed in the post-op period. Smoking and alcohol, I told the recommendation very strong. They should be stopped. Both should be 4 weeks before the surgery because they affect that intra-op tissue oxygenation, wound infection in the post-op, pulmonary complications in the post-op and intra-op period, as well as the thromboembolism chances are increased. So they should be stopped and patients should be properly consulted for them. Now, very important is the glucocorticoid. Should we give or should not be given? It's a very strong indication in the ERAS protocols, where a low dose like 2.5 to 5 milligram of dexamethasone is given 90 minutes prior to the induction of anesthesia. It not only has the anti-inflammatory property, but decreases the surgical stress, post-op nausea, vomiting, and complications related to the discharge. If you come to the pre-op fasting, the recommendation is very strong. Level of evidence is high. The previous 8-hour fasting is now decreased to the 6 hours, and there is a fasting period of 2 hours before of clear fluids is allowed with minimum patient thrust and improved post-op well-being. So if you see this chart, the adult and children should be encouraged to drink the clear fluids at least 2 hours before the surgery. And it is a very strong 1++ and A recommendation for that. While the solid food should be prohibited for 6 hours before the elective surgery in adult and children. While the patient with obesity, gastroesophageal reflux, and diabetes can safely follow all the above guidelines. Earlier, it was for the obese and pregnancy, it was 8 hours, but now 6 hours is the standard protocol and should be followed by everywhere with 2 hours of the clear fluids. So again, another thing becomes the carbohydrate loading. How it is important? If you see, it is seen to reduce the post-op thrust, hunger, and anxiety. Intra-op, it helps in managing the metabolic stress and insulin resistance. How much glucose should be given? The question comes to the mind. So pre-op carbohydrate loading using isomolar drinks night before surgery and 3 hours prior to surgery. Total of 120 grams of carbohydrate is allowed. It is safe in the non-insulin dependent diabetic patients, and no adverse effect is seen as a hyperglycemia or delayed gastric emptying. And the fluid should be made to the 200 ml. However, the monitoring of blood glucose level should be carried out at regular intervals in diabetic patients. All the recent guidelines recommend the use of this glucose because it decreases the risk of post-op nausea, vomiting, and safely included in the bariatric surgery protocols. So if you see from the Germany, the Scandinavian, the Aspen, the United Kingdom and European Society of Anesthesiologists all recommend major surgery and elective surgery of glucose carbohydrate preloading before the surgery. The next is the intra-op. No sedation should be given before the surgery. This is for the main ERAS protocol. Short-acting IV drugs prior to epidural spinal analgesia are allowed. And intra-op minimal invasive procedure, anesthesia plan should involve the opioid sparing, good multimodal analgesia, AFA management, ventilator strategy, monitoring depth of the anesthesia, fluid management, post-op nausea and vomiting, and no drains should be kept if possible in the post-op. So, and monitoring, if you see from the BIS scoring to the top, the esophageal Doppler, glucometer for sugar, and pupillometer for the depth of the anesthesia is another thing which is now included in the ERAS protocol. Again, the fluid directed fluid therapy should be given. It should be goal directed, and intra fluids are not needed to prevent rhabdomyolysis and maintain the urine output. Remember, the stroke volume variation facilitated goal directed fluid is the need for the ERAS surgery. And how it is given, if you see a clear side like fluorotech that we are used for this nowadays in the goal directed fluid therapy, it should help in the optimized fluid administration 10 to 15 minutes following the epidural bolus, abdominal insufflation, or changing the patient position. The SVV value should be measured, which is stable. If SVV is less than 12%, fluid status stable, no interop in other fluid therapy is indicated. If it is more than 12%, fluid deficit versus SVR decrease should be assessed. If there is a fluid deficit, 250 to 500 ml of bolus should be given of steroids. If the SVR is decreased, administer a vasopressor, VSS status every 15 minutes. And you should always measure the SVV trends. It is not a single value, but a continuous value. While the factors which affect the SVV accuracy are cardiac arrhythmias, the spontaneous ventilation, and change in the intrathoracic and intra-abdominal pressure. So at the time of insufflation or desufflation, you should know the values of the SVV may be altered. Again, if you see, liberal administration of fluid may impair pulmonary, cardiac, and GI function and lead to post-op complications of pulmonary edema, tissue edema, and prolonged recovery. So, goal-directed cardiac output measured IV fluids alone or in combination with inotropes during the perioperative period is the need for ERAS surgery. So, if you see this thing for the normovolemia, the patients, the complications of hypoperfusion, which is with the hypovolemia, are decreased, while for the edema of the hypervolemia, both are preventing, and it is the best period where the least complications are present. If you see this, this is the red graph. You see this is the measure where the estimation of fluid level, that is, if we are trying to capture it is a normovolemia or slightly hypovolemia, can help in the early discharge of the patients. Now, post-op nausea vomiting, I told, very important topic. A multimodal approach is needed. It involves the avoidance of the volatile anesthesia. Nitrous oxide should not be given, minimize the introp and post-op opioids, and avoidance of the fluid overload. And if possible, combination of the two antiemetics, dexamethasone and ondansetron or metoclopramide, should be given in comparison to the single drug. Now, coming to the ventilator strategies during for the ERAS, intraoperative IPPV is always considerable. Lung protective ventilation should be adopted in the bariatric surgery, while if possible, patient should be kept in the Andy Tunderberg with flex hip, anti or beach chair position. Okay, it is not always necessary that you will be allowed for this position, but if possible, you should try to keep for these positions. Neuromuscular blockage, I told you, it should be TOF guarded with TOF ratio more than 0.9 for the full recovery. Depth, if possible for you, the Sugammadex, if available along with you, you should use it, especially in the bariatric and colorectal surgery where the long surgeries are done. Again, hypothermia management, I told you, very important because it adversely affects the coagulation system and pharmacokinetics of the drugs, and it increase the metabolic requirement of blood and oxygen consumption. So you should be able to keep the temperature more than 36 degree core temperature with warming drapes, forced air blankets, warm IV fluids, and warm glasses in the laparoscopic surgeries. Post-op, very important, where the analgesia, opioid sparing, lung expansion strategies, and prevention of nausea and vomiting are the main part of the anesthetist. Apart from the discharge, post-op nutrition, early ambulation, and thromboprophylaxis, they should focus on these points, which involves non-opiates like IV acetaminophen and NSAIDs based on ideal body weight. Opiate, if possible, should be avoided, and if to be given, small boluses to be given. Wound and peritoneal infiltration used extensively. Blocks like apart from the regional anesthesia technique like the total epidural analysis spinal, the blocks, appropriate blocks in the post-op like TAB blocks, QL, quadratus lumborum blocks, erector spinae blocks, PANG blocks, the area specific block should be given. And the analytic regimen is specific to the type of surgery, as I told you. So if you see, our main purpose is from the more effective to the fewer side effect. The one, we have to choose this one, so that we have to replace the opioid with non-pharmacological adjuvants, NSAIDs, and acetaminophen along with regional anesthesia. So we have to remove this red chunk and have to add all these chunks to make it more effective and fewer side effects. Again, thromboprophylaxis, as I told you, it's already a domain of the surgeon, but we should know that 50% of the mortality in post-op is due to thromboembolic events. So if required, low molecular weight heparin or unfractional heparin should be added as per the surgical protocols. And important part from the anesthesia is that we should have the early posture mobilization with pain relief and calf length compression by stockings to decrease the deviating. Post-op clear fluids should be initiated as early as possible if there is no chances of ileus, and protein intake and average intake should be enhanced. The strict glycemic control is a part of the anesthesia and should be managed with the sliding scale or whatever the protocol is approved in your institute. So early ambulation, I told you, should be allowed if it is a daycare type of surgery and it decreases the chance of venous thromboembolism. Lung expansion by spirometry, by active cuffing, and prophylactic CPAP if required. And in the obese patients, you should always think of routine oxygen therapy by nasal cannula or prongs, regional anesthesia with short-acting anesthetics. OSA therapy, patient was always a OSA patient on the CPAP, you should give it. And patient with the known case of OSA, you should keep it on the BiPAP or NIV for post-op 24 to 48 hours if required. The result, are they do really work? They are the randomized trials for meta-analysis. Yes, there are. They have shows that ERAS protocol decreased the complication by 50%. It is the outer result of the 6 major RCTs by now and shorter the length of the stay by 2.5 days. Apart from that, it decreases the cost per patient. Although the study was done in the New Zealand and they calculated in the New Zealand dollar from the significant, where p-value was quite significant. So not only the length of the day hospital stays, as well as the cost is decreased with the ERAS protocol. What we follow in our hospital is that we educate the patient, give the clear fluid and carbohydrate 2 to 3 hours before the surgery. We go for the narcotics sparing and multimodal pain therapy, goal directive intra-fluid therapy, active intra-warming, routine administration of prophylactic antiemetic, minimum invasive surgical technique, which is done by our surgeons. We prefer not to keep any urinary or residue if possible, and early ambulation and enteral nutrition wherever is recommended. So this is the ERAS protocol in our hospital where we do most of the bariatric surgery and colorectics, Whipple's, other type of surgeries. So there is a slightly changes in every type of surgery. If you see for the neurosurgical, the main important is goal-directed therapy. Cardiothoracic, post-op multimodal analgesia is important. Abdominal surgery, the early feeding, post-op multimodal minimal and avoiding use of drains. Pediatric surgery, carbohydrate drink, goal-directed fluid and hypothermia. Orthopedics, early mobilization, multimodal analgesia. Gynecological, early feeding, early mobilization, screen for malnutrition. Ops, early mobilization and early feeding. So if you say most of the recommendation are for the anesthetists, they are the main part and they should know what special recommendation is to be applied in this type of surgery. So in short, I will say that there is a paradigm shift to the ERAS from the general elective surgery. NS recovery after major surgeries are evidence-based patient-centric guidelines. Multidisciplinary team is at the core of the ERAS. It decreases the length of stay and post-op nausea complication and it is cost-effective. And at last, the happy patient is very happy if he discharged early. So with this, I would say that this was my presentation and I open for your questions. Thank you very much.
Thank you so much for finishing it in time. Like ERAS, we send patients early home.
Thank you, sir.
And I think what's more important is in this ERAS business, the surgeons may like to take the credit because they deal with the patient directly and say that I'll send you home next day. Yes, but it all started with the anesthesiologist improving their system so that post-operatively patients would be painless, comfortable, and all that. And I think once one thing leads to the other in ERAS. Yes. Like if patient is shivering, like if I can tell you from my own experience, if I'm shivering for 1 minute, at the end of it, you will feel so exhausted because every muscle and fasciculating and everything, your oxygen levels, your release of the adrenalines and all those stress hormones in the body, they will make the patient not so comfortable to go home early. If the patient is not hydrated well, they'll tend to vomit more, they'll have more complaints. So once we had multimodal analgesia pitching in, I think that was the beginning of the probably ERAS, which now it is that now we are thinking that we do the surgery and send them home as early as possible. So now we have 3 very important topics on ethics, simulators and ERAS. So I think we can have questions and answers from the participants who are there, the audience.
Sir, as of now, there are no questions in the chat box. No queries from the delegates.
So I think that makes the all the lectures very comprehensive, so that everybody understood what they were told to. In that, do we?
I think there was, sorry, for interrupting. There was one query regarding fidelity in simulator. Whether how to define fidelity, what is exactly high fidelity, and whether it depends on the, will there be a difference in fidelity between participant 1 and participant 2? That is what. So, like I said, fidelity, if you just look at the definition, typically in definition, they talk about the equipment fidelity. But as many authors, including Miller, have said that in anesthesia, fidelity is the entire situation. So we have to look at, first we have to define the different aspects of the situation that we want to replicate. Say, suppose we are looking at massive bleeding in OR. That is the ACRM situation that we have made. So then we have to define those 15, 20 aspects that are very important for everyone to learn. And against that, we see if the scenario which has been made is comparing, and that will define the fidelity ratio. And for that reason, to make a standardized education material, we have to pick up some particular fidelity points and compare. But definitely for individual to individual learner, there will be difference. That is why in most of the simulator trainings, we have the debriefing sessions, which are very important, and that each simulator, each learner can then discuss, and some of the learners may need to repeat that session to relearn the objectives better. So fidelity is more of a determinant of a pre-learned set of standards, which are specific to each simulation training that we are going to make. So that's the answer.
Actually, if you see anesthesia has a lot of technical inputs in terms of machinery and equipment and everything, and the procedural details, right? So both of them, when taken care of with simulation, and artificial intelligence now coming in, is going to make simulation even much more pleasurable and useful in future.
Yes.
Right. So, like if my needle is, I'm giving a block on a simulator, even on a simulator, and I'm putting it in, the AI system will tell me, where are you going? Why don't you turn little right, left, or deep, or this thing. So I think for anesthesia guys, like any other, like say pilot, we have to take very instant decisions, very vital decisions, which can make or break the whole thing. In anesthesia, this will be a great thing when we have experience on a machine kind of a thing, rather than on patient and having complications in the actual situations.
Yes, right.
Dr. Chaudhary, anything more you want to add on to ethics? You are on mute.
You're mute. So can you, Kapil sir, can you unmute yourself?
Sir, I think the ethics involves everything, the simulation or the ERAS, everything to the shortest point I've covered as relevant to the postgraduate. Ethics itself is such a big session that even 2 days are not sufficient to cover ethics.
Even whole life is not enough.
Yeah, true, sir. So just we have to ensure that we are doing something which is in good intention and there is not causing any harm, and it's and respect the patient autonomy and lack of coercion. That is the basic elements of ethics, and they are applicable in all the techniques, whether it's ERAS, simulation, OT, ICU, anywhere. Sir.
And from the practical point of view, I would like to emphasize one thing on our young learners. In our situation, especially, I mean, in comparison to the European and Western civilizations, there will be many shortcomings from the patient side, from the doctor side, from the situational side, from the institutional sides, where we will feel that ethics probably would be compromised either way. I mean, you want to be socially more comfortable, and you'll find that ethic comes in the way. But as the times are coming with medical legal issues and the sensitivities of the patient, people are coming, ethics must be followed to the T, and you must make sure ethics are followed and not have any shortcuts on that, because they can lead us to some trouble.
Yes, sir. That is why
Yes,
even
sir.
in the foundation courses now, the new entry MBBS graduates are also
Yes,
having
now
a
a part
session
of-
on ethics, so that they are inculcated from the MBBS level, and in every specialty, not only anesthesia, ethics in medical profession and in other professions also needs to be followed.
Like, I'll give you a simple example. Now, a patient comes who's a diabetic and he says, don't write diabetes, it's not entered in my insurance.
Yeah.
No, it's not my insurance.
Yeah, true,
So
true.
don't
Yes, sir.
mention it there. Now, you which principle of ethics do we put in here? Then the ultimate ethics is that it is there, so we are putting it. Finished.
Right.
Social is, we can't help now. Right? We
True,
used
sir.
to do it in the past, but probably no more.
Yeah.
And about the ERAS,
Sir, what I say, you have already beautifully summarized the ERAS, but I think daily we learn something from the ERAS. In OT, every
Yes.
complication leads us to learn something, how our patient should recover in post-op, and what are the things that we are really making the mistakes that makes the delayed recovery. So every patient, we are learning day by day, and we are improving our ERAS skills. And one should be vigilant enough to know the mistakes and admit them.
I think vigilance is probably
Yes,
the
sir.
most important thing, because if you can anticipate what's going to happen in the next few minutes, you can avoid that, and the
You
patient
can
can
avoid.
go home early. Because with my personal experience from Irvin Hospital, which is now Loknaik Hospital, where we used to do DNC and MTPs day in, day out, tens in a day. I was doing anesthesia for same thing in one of the nursing homes. I gave anesthesia, patient was out, went to the post-operative room, and then suddenly the gynecologist rushes to me, usko nausea ho raha hai. So the first
Yes,
thing
sir.
which came to my mind was, because where I came from and where I was working, that was not part of my anesthesia, this thing. But then later on, we were taking care of it from the pre-operative period,
Yes.
during the operative period, so that such a situation doesn't arise. And
Do
the
not
patient
arise.
going home after an hour and a half or two, whereas in Irvin Hospital, sometimes they were lying down late in the evening also, not feeling like going home. So once we are vigilant and this thing, so ERAS is basically taking care of not letting complications set in, and think beforehand what is going to happen.
And sir, preventing the complication is also the ethical responsibility of anesthesiologist.
Oh, yes.
Yeah.
Even
Like
if
the
it is,
ISA recommended that you need to take care of the ethics in pre-op, intra-op, and post-op, and post-op is still discharge. So just shifting the patient out of the OR does not shrug you off the ethical responsibility till the time the discharge is due.
and in a lighter note, anesthetists should always remember that whatever happens is their ethical responsibility.
Yes, sir.
Because surgeon will
True.
anyway put it on you.
On you.
So I think with all this, we can call this session off. Thank you very much. All of
Thank
you
you, sir.
have presented very
Thank you,
well.
sir.
Thank
It
you,
was
sir.
actually enlightening.
Thank you.
Thank you, sir.
Okay.
Thank you so much, sir, for your contribution. And thanks to all the speakers for such wonderful presentations. And thank you. Thank you.
Dr. Kavita is waiting in the wings. Welcome, Dr. Kavita. Okay, thank you so much.
Thank you so much. So we'll move on to the next session, which is a short case presentation of a 4-year-old child with hydrocephalus and meningomyelocele posted for peritoneal shunt. And for this, I would like to invite a very eminent faculty with a vast teaching experience, Dr. Kavita Rani Sharma. Ma'am is Director Professor,